All right, so this is a chest x-ray of a man who is in severe acute distress. This is an incredible case that was sent to me, and there are so many very important teaching points here. So let's go through and break this down and extract as much information as we can. Then I'll shed some light on the clinical context, the clinical picture, and I'll tell you exactly what happened. All right, now right off the bat here, we can see that this is a portable chest x-ray shot with the patient at 45 degrees. So we know that he is sitting up. Looking at the bilateral hemidiaphragms here, we can't really see the costophrenic angles because they are cut off. They are inferior to the field of view here, but we can extrapolate that they are likely both deep. This circular structure here, this rounded structure, this is the aortic knob, and this is the contour of the descending thoracic aorta. This is the heart here, and this is the left heart border. These guys, these things, there are 1, 2, 3, 4, 5 of them. There's a fifth one here that is obscured a little bit. These are cardiac leads, cardiac monitors, and they have their respective wires, and they head off inferiorly off the screen as well. This tubing here is likely IV tubing related to a left upper extremity IV, and this tubing coming straight down and then going off the screen here. This is an NG tube that appears to be headed towards the stomach. All right, now let's look at big things. Let's start by looking at this side. This is the patient's right side. Right off the bat, you have to make this diagnosis. This is a pneumothorax and is a very large one. You can actually see that this line here, this is the lung line. You could trace it up here. This is the lung being smashed by air in the pleural space that does not belong here. That's what a pneumothorax is. And you can see that this is very lucent down here. There are no lung markings lateral to this line. And you see that there's patches here of hypodensities. And here, this is just straight black. This is the classic appearance overlying the trapezius muscle over here of subcutaneous emphysema or subcutaneous air. All right, now let's go to the other side, this side. Now, the question you have to ask is there also a pneumothorax here? Now, we already said there's likely a deep sulcus here, and it looks a little bit lucent here above the left hemidiaphragm. And look again, there is very significant subcutaneous air, not only overlying the left trapezius muscle, but overlying the left latissimus muscle as well. Whenever you see this in this clinical scenario, you must assume that there is also a pneumothorax on this left side as well. So bilateral pneumothoraces. Granted, this one isn't as big as the one on the contralateral side. All right, now, if you look closely and you notice that there is a black stripe here, if you notice this, that's very astute. This looks like pneumopericardium, but I'll tell you that there was no pneumopericardium here. This is just that extensive of subcutaneous emphysema that is scattered, and it's giving it this appearance. In fact, it is so extensive that it looks like there's multiple rib fractures here, but there are no rib fractures. In fact, this wasn't a trauma. This wasn't a trauma at all. This was a post-operative patient. And if you look closely here, you can see these little linear dentures on the right side of the face, jaw, neck here. These are surgical clips. Intraoperatively, the patient had a tracheostomy that was placed. Now, you can't quite see the tracheostomy tube here because of the angle that this film is shot. The patient's also significantly rotated here, and there are overlying structures. But one thing that we know, just by looking at this film, there are bilateral pneumothoraces, and there was a recent tracheostomy that was placed that apparently earlier in the day was exchanged. You must conclude that the culprit is the tracheostomy. Now, prior to this film being shot, the maneuvers that were performed were excellent. Here's what you have to do, and this was done. You must supply oxygen both over the mouth and over the tracheostomy tube, and that was done here. It looks like there is a non-rebreather over the mouth. This is the tubing from that, and this corrugated tubing here, you see coming down here on this side, this is oxygen over the tracheostomy tube. Now, at the point that this x-ray was shot, you know that this patient needs emergent bilateral finger thoracostomies followed by chest tubes. But in terms of troubleshooting the actual tracheostomy, what you do is you think about two things always in this scenario. Number one, obstruction, and number two, displacement or dislodgement. And the way you assess for that, and it sounds like that was done very adroitly in this situation, is you feel for air movement over the tracheostomy tube, in and out. And that was done here. Ideally, if you have end-tidal CO2, that would be perfect. Next, to address obstruction, you pass a suction catheter, and that was done here. And it passed. If it doesn't pass, you have your answer. There's an obstruction. But if it does, that implies patency of the tube. Now, in this scenario, both tests were passed. So that leaves us asking, what the hell is going on here? And what do you do next? Well, I'll tell you what you do next. You do next what was done in this case, fiber optic bronchoscopy. That is the gold standard in this scenario. That was brought emergently to the bedside. A fiber optic scope was passed through the tube, and it was lying within the trachea. But what was found at the end of it is something that is very rare, and you may just see case reports of this. There was what looked to be maybe a piece of soft tissue that was acting as a ball valve. And the effect of that is that the patient is allowed to breathe in, and it's open and patent, and the patient takes a deep breath. But then when the patient exhales, it closes. And that's a ball valve effect. And slowly over time, air will accumulate, and over hours, this will lead to this. And that's exactly what it sounds like happened in this scenario. The tube was exchanged for a deeper tube that bypassed that anomaly. The patient got bilateral emergent finger thoracostomies followed by chest tubes that you see here. And look how impressive the evolution of this subcutaneous emphysema is. I mean, this is as bad as subcutaneous emphysema as you'll ever see. But notice the chest tubes are placed into the thoracic cavity very nicely here. They are in an apical position as they should be. And notice the break in this line here. This is the sentinel hole, or the last hole. You see it on both sides here. This must be within the thoracic cavity for the chest tubes to function. These are both well within the thoracic cavities. And if you think this is impressive, wait till you see this next film. This is fast forward to 1 week later. Watch this. Boom. Both chest tubes have been removed. The lungs are up, and they stayed up, and the tracheostomy tube was removed. The patient no longer needed it, and all that extensive subcutaneous emphysema has almost completely resolved. There are little bubbles here that are residual, but this is very, very impressive. This patient ended up doing very well. He was discharged home in excellent condition. But during these moments, this was a very critical portion of his hospital stay. His life was literally in danger. But the physicians taking care of this patient knew exactly what to do. And that's why it's so important to understand the principles that we talked about here. And that's why it's so important to keep learning and keep growing and sharing these cases with other people. Because I promise you, no matter how long you've been practicing medicine, you will never cease to be humbled and amazed by the things that you see.